Um, Welcome everybody to our first Genomics webinar. It's wonderful to see so many people join us on the call, and I'm sure a few more will join over the next few minutes. My name is Stephanie Bell, and I'm the Early Diagnosis Programme Director over at the Surrey and Sussex Cancer Alliance. And it gives me great pleasure today to welcome everybody here, especially our guest speaker, Dr. Debbie Hips, who's joining us from Mexico. Debbie is a GP and genomics expert. Debbie was also recently appointed as the primary care lead for the South East Genomic Medicine Service, and today she's going to guide us through an introduction to genomic medicine and when and how to refer patients. Just want to go through some housekeeping first. The webinar will be recorded and the slides and the recording will be shared after the meeting. Can you please keep your cameras off and your microphones on mute unless you're speaking? If you do have any questions, please can you put those in the chat box, and we will do our best to get through those in the Q&A session. If not, we will follow up by email to the group. I just want to note as well that for those that did submit pre-submitted questions, most of those will be covered in the subject matter today. There were a couple relating to Lynch, and they will be picked up in our next webinar. Finally, there will be a feedback survey at the end of the webinar, so can I ask that you have your mobile phones ready to scan the QR code? If you don't have a mobile phone, we will pop the link in the chat. And now I will hand over to Debbie.
So I'm a GP trainer in South London, and before medicine I did have a previous career in pure science. I did a PhD in molecular recognition, and that's because I had an interest in genomics generally. I thought I might go into oncology, but became a GP for various reasons, became a trainer, and following my interest, I've then done a master's in genomic medicine, and off the back of that have become the primary care lead of the South East GMSA. And it's in that role today that I'm presenting to you because my role involves trying to upskill general practice and get us all ready for the genomic medicine changes that are rapidly happening and going to carry on happening more and more. I wanted to tell you really a bit about genomic medicine and about why it's so important. It's obviously, from the name of it, perhaps the application of genetics into medical care. And it's important because it allows us to have much more detailed understanding of what's going on and personalised medical care. And in the future, it's going to have a big impact on how we deliver care. The NHS England has a genomic medicine strategy, which talks about accelerating genomic medicine in the NHS and embedding it across all levels of care, from primary through specialist and tertiary care, and delivering equitable access so that everyone benefits from it. We want to enable genomic medicine by developing data and digital applications, and there's a lot of science research and innovation that's going to drive all of this. In order to deliver this, the NHSE developed 7 regional alliances, and we're the bottom right yellow one, the South East, and the alliance consists of a laboratory hub and a regional genetics service, which is based at Guy's and Thomas's and St George's, and also then the GMSA itself, which has an educational and training role. If we look at what the RCGP thinks that a GP should be doing or understanding in genomic medicine, I think the bottom line of this slide is the most important one, that we understand how genomic information can be used in clinical practice. But where it is practically applied comes in perhaps at the top, with taking family histories, identifying patients who would benefit from being referred to appropriate genetic services, managing patients who have genetic conditions and coordinating their care and communicating both with them and their secondary care providers. Then if we think practically what different things we see in primary care, we obviously see the family history of cancer risk assessments, also managing patients at raised risk of cancer, other genetic diseases like hypercholesterolemia, other odd symptoms like rare diseases, how we do genetic testing in primary care, what sort of options can be offered to people who do have genetic disease, how some of our patients might be involved in genomic medicine trials, how they might present to us sometimes with direct-to-consumer test results, what infectious disease management is looking like currently, and lastly, pharmacogenomics. Now, I can't cover all of that in an hour's webinar, so I'm basically going to concentrate on the family history of cancer and risk assessment, how we manage a patient who's at a raised risk of cancer, briefly look at other genetic diseases and doing genetic testing in primary care, and then very, very briefly, a little bit on pharmacogenomics. So yeah, I've just told you all of that. Slide. So starting off with a family history of cancer. This is a common presentation in primary care. Your patient may, you'll see maybe one or two of those every month. Someone coming in to say, everyone in my family has cancer. My mum had breast cancer. I'm worried. What can you do? What can I do to reduce my risk or to evaluate my risk? So if we think about cancer, we know that all cancer has a genetic change, but not all of it is inheritable. Some of it is somatic changes, changes that have just happened in a particular tumor tissue, rather than germline changes. Only germline changes would be able to be inherited. And then we also know that cancer has a multitude of different influences that might be involved in it arising. And a small percentage of those are genetic. That at the right end of the arrow, the red end, we have approximately 5% of cancers arise from genetic factors. On the other side of the arrow, the blue end, a lot of factors are environmental. And then in the middle, there are polygenic factors, where there are small genetic factors that contribute individually and add together to raise risk. And we use family history analysis as a way of assessing risk. So if we think about our hereditary cancers, as I said, a small percentage are inheritable, and most commonly the ones we'll see are the breast and ovarian and colon cancers. Smaller numbers of other cancers are inheritable. Prostate and pancreatic can fall into the cancer predisposition syndromes. So if we think about genomic changes in the BRCA genes, we know that will raise, BRCA1 will raise breast and ovarian risk. BRCA2 changes can also have prostate and pancreatic risk. And then the Lynch syndrome changes, which we'll discuss in a lot more detail in the next seminar, can have widespread raised risk of different cancers. So why do we want to identify hereditary cancer? That is because it can inform treatment options, so help us to decide which medications, which therapies would be most effective. It can help us clarify prognosis, risk of further cancer in that patient. It can help that patient make family planning decisions, and it can also identify risk reduction options. And finally, if we identify hereditary cancer in one person, we can cascade test to their family to identify pre-symptomatically the risk in that patient and manage it. So what makes us think about inherited cancer? What are the red flags that make it lift into our heads? Firstly, we're doing our risk assessment by evaluating the family history. We're asking ourselves, is this cancer a type that is associated with a predisposition syndrome, or are there several cancers in the family that might link together to be a predisposition syndrome? We need to ask, is my patient ethnically at raised risk? We need to think about cancers that are appearing at a young age, being more likely to be inherited, or perhaps a cancer that is appearing in an unusual sex, for example, male breast cancer is much more rare than female and might be linked to a predisposition syndrome. Are there bilateral or multiple primaries or multiple family members with the same cancer or different cancers associated with that predisposition syndrome? And we use that history that we've gathered to stratify the risk of our patients to either being near population or above population risk. And then we use appropriate management once we've made that decision. So this is just quickly clarifying that there are two types of testing. We have diagnostic testing for someone perhaps who's the first family member to be tested. They may be clinically affected, or they may have a family history that indicates raised risk. But then if we are doing cascade testing, we're doing predictive testing. We know there's a mutation in the family. We are trying to find out if that individual is also affected. So if we take a practical case example, we've got a 42-year-old woman who's come into our surgery this morning, and she's worried that she might be at risk of breast cancer because her mum had breast cancer at the age of 45. She wants to get tested. She also thinks everybody else on her father's side also has cancer. Her father had something on his forehead that was cancerous. His sister had lung cancer, and his mother had cervical cancer. So first of all, we think, can we draw a family history tree? Do we need to? Perhaps with this history, it's quite simple. We could manage that very quickly. And then we need to make that evaluation. Is this lady at near population risk or raised risk? Do we think there's possibly a predisposition syndrome, a genetically inherited risk? So to evaluate that, one more thing to consider. I mentioned that ethnicity has a role in your evaluation. Patients with Jewish ancestry have a much raised risk of having BRCA mutations. And if she is Jewish, she does get tested. And in fact, there is a special route for testing, and patients can refer themselves. So you might consider sending this information out to anyone who you're aware of in your practice population who is Jewish, because they can be tested without any history of breast cancer. So we're assuming this lady is not Jewish, and we are then looking at trying to evaluate, does she need referral or not? So my recommendation for you, we've made a little flow chart here, which I'm not sure whether you can read or not, but you get out your NICE guidance because you can't remember all of the little details of the risk assessment. And I personally like the CKS version of the NICE guidance because it's very clear. But we, thinking about this lady, she falls into this column here. I'm not sure if you can see my mouse. And she has a single relative who is not under 40 and had unilateral breast cancer, and she does not meet the criteria for referral. She is at near population risk. Her likelihood of genetic cancer is less than 3%. So we are going to attempt to reassure her. We are going to talk to her a little bit about how she can manage her own risk, because we will recognise that her mum had breast cancer relatively young, and she probably does have some perhaps polygenic risk. Breast cancer is also very common. 1 in 8 women get breast cancer in their lifetimes. Inherited cancer, however, is less common. We very much want her to return if her family history changes. We want her to be breast aware. There's a great website called Copperfield, which you can direct her to. And we want her to engage in the NHS breast screening programme. Once she reaches 50, she'll be offered 3 yearly mammograms. Then there are some lifestyle and risk reduction advice you can offer. So what is her body mass index? What's her diet and exercise like? How much alcohol does she use? Would she be thinking about contraception or eventually HRT? And is she going to be, or has she done has she managed breastfeeding? Has she had any babies? So the British Menopause Society has produced this poster, which I really like, because it just shows in a very pictorial way the lifestyle risk factors in breast cancer. So that top line shows the background risk of breast cancer. So this is for 1,000 women aged 50 to 59. You may get 23 cases of breast cancer. And this is developed because it's looking at additional risk if you offer HRT, which is very similar to the additional risk if you offer combined hormonal contraception, a few extra cases. But if you look further down this chart, women who drink 2 or more units a day have even higher risk than if they were on HRT. Women who are smoking have raised risk, and women who are overweight or obese, unfortunately, have almost double the risk. And then risk reduction efforts could be to exercise 2.5 hours a week, and that will bring your risk down very nicely. So I think that's a really nice way to share risk and how to modify risk with lifestyle. So if we go back to our case and we add a second member of her family, so not only her mother, but also her maternal grandmother had breast cancer at age 40. Sorry, her mother had breast cancer at age 40 and her grandmother at age 70. She now falls into the middle column on my little graph here, and she does then fall into a raised risk category, and we would like to refer her. The most common pathway for referral for evaluation of raised family risk is into a local family history clinic, and a lot of these are run virtually. And what happens with your referral, sorry, I should just say, if you don't have a family history clinic in your area, then it'll be to clinical genetics, and then they will direct it on to a family history subsection of their team. But what happens is that the referrals received, usually an electronic questionnaire is sent out to the patient to gather all the family history again to 3 generations. And that can be a stumbling block. So when you make that referral, do warn your patient that they will be sent out a questionnaire, and if they don't return it, they will be contacted by the admin team to try to nudge them to do that, or even help them to do it on the phone if they're not able to do it electronically themselves. But if that questionnaire is not completed, it's very difficult to make the evaluation of risk, because that's done using a online risk evaluation tool. Most commonly, the one used is called CanRisk. And that questionnaire output is fed into the CanRisk tool, and the tool spits out the risk evaluation. So it may decide that the woman is still at population risk. As I said, 1 in 8 women get breast cancer. Then, if not, she may fall into a moderate risk level or a high risk level. And the risk evaluation CanRisk tool will also evaluate whether genetic testing should be done for that woman. So whether there's high enough likelihood of a mutation to actually do the genetic testing. If we're thinking about doing genetic testing, we need to do some quite detailed counselling, because it's a little bit different to doing just a biochemical test, a full blood count, something like that, because of the implications of genetic testing. So they will reevaluate the family history and reevaluate the patient's concerns and their wishes, and explain the risks of genetic testing. So genetic testing is not a black and white test. You can get some black and white answers, but you can also get some very grey answers, which need to be pre-warned, that it may raise more questions than it answers doing the testing. So you have to discuss if that screening really is appropriate, and also the fact that if that patient gets a positive test result, then there may be implications for the rest of the family, and those need to be discussed in advance of doing the test, and then agreed on what test should be done, and then request it and carry it out. So the reason why genetic testing isn't always black and white is because genetic variation is very common. We all carry a huge number of variants from the reference genome, and they can be things like simple changes, 1 point change in the genetic code. They can be insertions or deletions of variable sizes. We can translocate big chunks of genetic material, or we can have different copy numbers and structural variants. And a lot of those, a large number of those, are benign. They are not causing any pathology to the patient. Then a small number may be pathogenic, and then a very significant further number will just be unknown. We just don't understand at the moment whether they're significant or not, and we can get hints on that depending on where it falls in the genetic code, but it can be very difficult to interpret. So there's a very complex pathway of evaluating the variants to produce a meaningful report, saying that most of these variants are benign, this one is significant and possibly pathogenic, these ones are all unknown significance. And that report would then be communicated by the genetic counsellor normally to the patient. So if we assume that this lady's now been found to be at above population risk of breast cancer, on the left column we have some underlying management principles. So we will likely get her involved in a surveillance program. And the family history clinic will link their patient to that surveillance program. It will not be your responsibility to do that. You'll get a letter saying this lady's at either moderate risk or high risk and has been referred to the surveillance program. So we then discuss the family history clinic would discuss possible risk reduction and give some specific information about what cancer is they're at risk of, lifestyle advice, either have done some genetic testing or explain why it wasn't indicated, and always be vigilant and to review if family history changes. So in the middle column is the management for moderate risk women. So they get annual mammography from age 40 until 49, and then they enter the breast screening program. And they can be offered risk reducing chemoprevention. It's really endocrine prevention. It's offering them estrogen blocking medication. And that was in the NICE guidance a long time ago, but it's patchily offered, I would say. And the part of the problem is that the family history clinics are mostly run by nurses. So you may get a letter saying your patient is at moderate risk. Please would you consider prescribing tamoxifen if they are premenopausal, or anastrozole if they're postmenopausal. And we are trying to develop the pathways currently to make this easier, to support general practice to initiate more in secondary care. But that's a slightly messy service at the moment. If they're in a high risk group on the right-hand side, it very much depends on exactly what the risk level is, whether there is a predisposition syndrome mutation, what sort of extra surveillance they can get. But that, as I said, will all be organised for the patient. They may be getting MRIs from a young age, mammograms yearly from 40 to 69 or 59. They will be recommended rather than offered chemoprevention, and they may, if they have a predisposition syndrome mutation, be also offered risk-reducing surgery, either a mastectomy or a salpingo-oophorectomy. And again, for those with the predisposition syndromes, they may get offered predictive testing of their family members. That's usually done by giving them letters to pass on to their family members, their first degree family members, usually firstly. And that will be a letter for that patient to take to their GP to then say, my family member's got this mutation, please can I be also tested for it? And that will prompt their GPs to hopefully refer them to the appropriate clinic. And then finally at the bottom is reproductive options. So we can do genetic selection to avoid passing on a predisposition gene to the next generation. And that can be discussed and offered if the patient is keen for that. So other aspects of care that we might be involved in, because we are their primary care providers, is considerations of contraception, HRT, and general sort of probably managing anxiety and things like that. So in terms of contraception, we obviously use the UK medical eligibility criteria to guide us. But actually what we want to do is an individualized risk assessment. So, you know, someone with a family history of breast cancer, but who is at population risk, is actually UK MEC level 1 for any form of contraception. If they're at raised risk, they can still potentially have certainly the progesterone-only forms of contraception. And even if you do an individualized risk assessment, it may be that you feel that for this particular individual, the risk of an unintended pregnancy outweighs the potential risk of breast cancer. And if we think back to that slide of extra risk, these women have very high, a woman who's carrying a BRCA mutation has a very high risk of breast cancer, and adding a little extra by offering contraception may not be that bad an option. And I should also mention here that BRCA1 gene carriers, they tend to have what's called triple negative breast cancers. So they're not hormone-driven breast cancers. And so you might think that someone with a BRCA1 gene mutation may well benefit from combined contraception. There's more guidance on that in the familial breast cancer guidance in NICE, the clinical guidance 164. And you might also consider there that there is a known benefit of the combined contraceptive pill at reducing risk of ovarian cancer, to add into your scales of evaluating the risk. The women who get risk reducing surgery, who've had BRCA carriers perhaps, who have the salpingo-oophorectomies, they should be offered HRT at the time of surgery. So, you remove their ovaries, but you give them some HRTs to ideally not plunge them into surgical menopause, manage their symptoms until normal age of menopause. So briefly touching on other cancers, the principles are the same, that there are screening programs for some cancers. We know there's a bowel screening program. There is no current screening program for ovarian cancer. We want them to be vigilant for symptoms. We want them to follow lifestyle advice, and we want them to return if family history changes. I'm not really going to cover the middle one because the colorectal cancers are very much going to be covered in our next webinar on Lynch. Just to say that we follow the British Society of Gastroenterology guidelines to evaluate risk. We look for that predisposition syndrome for Lynch, which involves bowel, endometrial, ovarian, renal cancers. And then screening will involve extra colonoscopies, either a one-off or regular colonoscopies. And for Lynch syndrome, some additional steps. Over on the right-hand side, we've got a column on ovarian cancer. There was new guidance publicised in March this year from NICE, which suggested that anyone with a first or second degree relative who had ovarian cancer could be tested for BRCA mutations. Currently, the service is lagging behind that guidance. The clinical genetics service would struggle to offer that number of testing. I think one of the pre-event questions was, what about all our patients with family histories of ovarian cancer? This is an issue. If you have someone, you can refer them. The service will do its best to manage it. So and at the bottom of this line is also the note that we know that contraceptive pill use is something that reduces risk. However, we don't want to offer it as a risk reduction strategy because it's not quite clear enough that there aren't confounding factors. So in cancer management, there is quite a lot of genetic testing going on. So there are trials looking at detection of small free-floating DNA fragments, so cell-free DNA, that might allow early detection of cancer, and that's running in the Galleri trial, which you may have heard of in the press, or possibly even have patients recruited into that, although I think it hasn't been very active in the southeast. They're also looking at whether cell-free DNA can be used to monitor patients after cancer treatment, looking for early symptoms of signs of recurrence. We also use tumor testing to direct many of our cancer therapies and to look for mutations that might predict metastatic spread. And we use genetic tests in cancer treatment to guide optimal dosage and avoid adverse drug reactions. And that's a bit more pharmacogenomics, which I'll, as I said, talk briefly about later. So I want to move away from just cancer and look at a few other genetic diseases that your patients will present with. So very commonly, you'll be dealing with people with familial hypercholesterolemia. It's very common in the UK. About 1 in 250 people will carry genes, mutations that give them high cholesterol levels and high risk of premature cardiovascular disease. And a lot of these people are not yet diagnosed. We know that familial hypercholesterolemia is inherited in an autosomal dominant fashion, and the mutations are mainly in the LDL receptor, the ApoB, and the PCSK genes. And that accounts for 93% of familial hypercholesterolemia. So we're already doing our NHS health check age 40, looking at hopefully getting people in to do a check on their lipid values. We might notice that there's a very high family history of cholesterol or even premature cardiovascular disease, or we may spot signs on examining our patient like ARCUS and xanthelasma. And we'll follow excuse me, the Simon Broom criteria to decide whether they require referral to the lipid clinic. The point of doing that is to access that genetic testing, and then that will allow us to offer cascade testing and new treatments for managing super high cholesterol levels. Obviously, we will also stick them on a statin as soon as we diagnose it, but maybe some of them will not tolerate it, so they may need different treatments. We then think about more rare diseases. So approximately 70% of rare diseases do have a genetic basis, and collectively a rare disease is common. So rare disease is something that affects 1 in 2,000 people, and there are about 8,000 of them. So the lifetime risk of a rare disease is about 1 in 17. Approximate prevalence about 5%, often a delay in diagnosis of about 5 years. And many of them may have symptom onset in childhood. So rare diseases will include some you're very familiar with, like cystic fibrosis or Guillain-Barré, and some that only affect a tiny handful of patients worldwide. We might suspect those rare diseases either from the family history again, or from odd symptoms that are presenting and often in combination. So I want to talk to you a little bit about cystic fibrosis, and I want to talk to you about that because that is something we can actually do a genetic test for. So this is our case example. This lady is walking into our surgery again. She's 25, she's 6 weeks pregnant, and her nephew has cystic fibrosis. Now we know cystic fibrosis is an autosomal recessive condition, so her sister must be a carrier. And she's anxious and wants to know whether her pregnancy could be affected. She's not affected herself. So we have to think through things. Is her risk of affected pregnancy the same as the general population? I think we'll all be quick to shake our heads and say no, she's at raised risk. Does she need to be referred for antenatal testing? Cystic fibrosis is screened for in the heel prick program. Well, that is true. It is screened for in the heel prick program for sporadic cases that are arising, but that does not mean that she shouldn't be referred. And in fact, this statement is also incorrect. There is urgency to pursue antenatal testing, because we want to do this as early as possible. She's only 6 weeks pregnant, and she may want to take action if she found that she was carrying a child with cystic fibrosis. So the bottom line is she is at risk of being a carrier. She and her partner will be tested, because only if they're both carriers would that make the child at risk. And CVS would be then offered if wished for. And ideally, that's obviously done 11 to 13 weeks. So I briefly said that cystic fibrosis is one of the tests GPs can request. All genomic tests are listed in something called a National Genomic Test Directory that you can get to online. The core tests are most of the cancer tests and some of the rare and inherited diseases, but there are some specialist tests in various areas that are, so the core tests are all offered by all of the genomic lab hubs. So the Southeast Lab Hub would offer all the core tests. The specialist tests are only offered by certain hubs, and samples are transferred from one hub to the from your local hub to the specialist hub. That's not really of relevance to us because we're not going to be requesting any specialist tests. The 3 tests we are allowed to request are cystic fibrosis carriers, testing for hemochromatosis, and testing for alpha-1 antitrypsin mutations. And I'm going to tell you a little bit about how you do that. So this is the page in the National Test Directory for cystic fibrosis carrier testing. The test is named R185. And on this page, we can see the testing criteria and who can request it. And you'll see there down at the bottom, general practice can request it. The bottom line is what test is done. So this is a targeted test for the CFTR, this cystic fibrosis transfer receptor, which is carries 93% of the mutations that cause CF. We can check our patient fits the testing criteria, and we can scribble down R185, and we can fill in a request form. This is just briefly the other 2 tests, the hereditary hemochromatosis and alpha-1 antitrypsin. I think that we're much less likely to request those. Certainly alpha-1 antitrypsin you do firstly biochemical tests and rarely need to do the mutation analysis. Hereditary hemochromatosis, you might do that test, or you might send them on to hematology to do the testing. We've decided that our patient does meet the eligibility criteria for CF testing. We want to give as much information as possible to the lab to make sure that it's accepted. If you need guidance, you could please do request either the lab or clinical genetics or myself to help. You complete the test request form, which is on the South East GMSA website. Also a record of discussion, that genomic testing discussion that I mentioned earlier. Collect a simple EDTA sample and send it to the local lab, where it will be sent to the genomic lab. This is the test request form. So you just have your patient demographic details, the clinical details of why you think they are eligible for the test, the EDTA sample you're going to send, and the R code from the directory 185 for CF testing. And then that form goes with the sample to the lab. This is the record of discussion, just saying that there are family implications, there can be uncertainty, you can get, well, sorry, it's unlikely there'll be much uncertainty in a CF testing result, because it's a very targeted test, and it's very unlikely there'll be unexpected information. We're not testing the whole genome here. We're not going to discover that they're at risk of some other horrible thing. The DNA will be stored and the data will be stored, and that's done because new variants are evaluated at all the time, and a variant that was of unknown significance may become a pathogenic or a benign variant in the future. So this is a very quick when to and when not to refer to clinical genetics. So do refer those women who are pregnant or planning pregnancy, who have a family history of a genetic condition. That may also include those with close consanguineous marriages where there's concern about risk. If there's a strong family history, we've already discussed. And then they're also happy to look at children, adults with learning disability and epilepsy and no current genetic diagnosis, because those are patients with possible rare diseases. They don't particularly, the clinical genetics service do not particularly want to see the hemochromatosis carriers. You can do the iron studies, do the genetic test, or refer to hematology. Alpha-1 antitrypsin carriers only if both parents are carriers and you're likely to get a affected child. Do not refer individuals with hypermobility and no other adverse effects, features, or patients with autism or intellectual disability and no other features. They're not very likely to be finding genetic causes for those. So I said I wanted to briefly tell you a little bit about pharmacogenomics before I wrap up. Genetic variants in an individual can help us to understand if a drug will work or if it might cause an adverse reaction. Currently, over on the right-hand side, we're going down the left pathway of this, the standard approach. We're prescribing by suck it and see. Try this one, it works for lots of people, maybe it'll work for you. And then seeing if we get the desired effect or if we unfortunately get side effects. And then we change the prescription accordingly. With a pharmacogenomic approach, we do a pharmacogenomic test in advance of prescribing, and that will help us to guide precision medicine. And that's the way forward. I'm sure you'll all agree, and that's starting to come. It's not here yet, it's quite a long way off, I'm afraid, but there are trials going on. And the NHS genomic strategy is clearly keen to use genomics to enable this. Currently, there are a few cases where pharmacogenomics is in action, but it's happening in secondary care. So patients who are prescribed 5-fluorouracil have genetic testing for DPYD variants to avoid toxicity. Patients with acute lymphoblastic leukemia are tested prior to treatment with purine analogues to avoid toxicity again. HIV patients are tested prior to being given abacavir to avoid hypersensitivity. We also know that there are a family of genes called the CYP genes that regulate metabolism of drugs. So CYP2D6 regulates, amongst other drugs, codeine. 8% of our patients are poor metabolizers and will accumulate codeine and get toxic side effects at small doses. And 2% are ultra rapid, the other end of the scale of metabolizers, and they are getting rid of the codeine really rapidly and need huge doses. And that's why codeine can be such a difficult drug to find the right dose of, and obviously we ideally want to avoid it. So there's a current new NICE guidance that came out in July 2024 on the CYP2C19 metabolic pathway, and that's responsible for metabolizing clopidogrel. Clopidogrel is a prodrug that needs to be activated by the CYP2C19 gene so that it can work. And obviously we're using clopidogrel for secondary prevention for stroke. And the new guidance is asking all our stroke clinics to test CYP2C19 to see the level of activity of the gene, and to avoid giving clopidogrel to the quarter of the population who will have an inability to activate the prodrug, and therefore find that clopidogrel will be doing no use to reduce their risk. That trial is currently starting at St George's to see how that can be run. It is going to produce some problems in primary care, and there's a lot of work going on behind the scenes to work out how to manage that, because clopidogrel is not the only drug that is metabolized by CYP2C19. And we need some coding to be able to add that to their patients' records, that they are have a variant perhaps, and what that implication is for other medications that we're prescribing needs to be put into our drug prescribing software. So pharmacogenomics is rapidly gaining pace, but it's not here yet, is the bottom line. But it's very exciting. And there's another trial that's happening up in the northeast, which is looking at doing a panel of genetic variants for the metabolic enzymes, and how to incorporate that information into the patient record and guide treatment for those patients. So the trials are happening. It will happen, it'll be rolled out eventually, but we're not there yet. So I've whizzed through rapidly. I've only got 5 minutes left for questions. So that's the summary of what we've covered. And this is a page on resources, so lots of different places you can get further information. Someone asked if they were really keen, how would they get to where I am. There is a master's at bottom line in genomic medicine, and there's funding via HEE to complete that, and you can do various stages of that. And there are lots of useful places to look for information in clinical scenarios, and I'd recommend that one in the middle called GE Notes. If you have a patient in front of you and you're not quite sure, you think that genomic medicine is involved, have a look in GE Notes for information, for practical information. And that is the end. And sorry, now I haven't left much room, but please, are there any questions? And if you want to ask me anything that you think of after this session, I've put my email at the bottom, and do join us on November 6th for the Lynch syndrome webinar.
Thank you, Debbie. That was absolutely wonderful. And fascinating presentation. I'm not clinical, but I found that incredibly insightful.